right, it is 5:30. Can everyone hear me?
Yes, we can.
Awesome. Good morning, everyone. What a beautiful morning. Thanks for joining us. This is, as everyone knows, this is our very first run of Decoding DX, so we're very honored that you all are joining us for this, especially at this time of the morning. Kudos to all the morning birds. So this first session is just going to be pretty quick. Ben's got a really awesome topic to just kind of walk through for us. Feel free to put in the chat if you have any comments, questions, concerns, really anything. We want the chat to be super active as we're going through this, and just to kind of increase the learning experience. And don't forget to join us tonight at 5:00 p.m. if you're available. We'll be walking through a case and doing some more teaching points with a resident, and it'll be super awesome. So with that, I'll hand it over to Ben.
Morning, folks. If you don't mind in the morning, pop your video on. That way, if you do chat and talk, we can see who's speaking, and it'll be a much more personal experience. So this morning, we're talking about EKGs. It'll be a really quick hitter. We're going to talk about the process, just kind of as an overview. I'm only anticipating getting through rate rhythm axis this morning. We can do some of the rest of it in more full discussion later, but in the nature of 5 clinical minutes, not 30 clinical minutes, this may end up being a couple of different times, and we'll re-hit the physiology and re-hit some of the core concepts a couple of times, and that's kind of the way that learning EKGs goes. So let me get this screen shared for you. All right, are you all seeing what I'm seeing, which is just a great little PowerPoint without any of the other mess from my background? Cool, thanks for the heads up. So EKG basics, physiology, and process. The folks who taught me how to read an EKG, Crane, Naylor, Wood, Kennedy, Apoli, and Briggs, are indebted for this. So basic physiology, you have 10 leads for 12-lead EKG, big shocker. One goes over here, one here, one down on the leg, and then, and then one on both legs. And then you have 6 that go around the precordium. Those are the precordial leads versus the limb leads, which are AVL, AVR1, or lead 2 and lead 3. Lead 1 doesn't exist. It's a calculation and a sum of 2 AVL, AVR, and lead 3. Wow, what a deal. So over here, you see positive, negative deflection. That's regarding to the amount of electricity coming from the heart towards the lead. If it is positive electricity, it goes up from the baseline. And if it's negative electricity, it goes away from the baseline. So you hear people talk about reciprocal leads. Those are leads that should show the inverse of the effect that you see in one lead if it's a systemic or an entire cardiac process. And so it's hard to have a perfect inverse lead. Let me get my pointer on here. I want the laser pointer. So it's hard to have a perfect inverse lead because AVL's perfect inverse is the inverse of AVL. But if you look over here on the opposite side with the AVR, you have a deflection here, and you have an elevation here. Here in 1, you have a deflection that mimics, or sorry. Here you have this elevation here, mimics deflections here and here. And so when you start putting your leads together, like this is the right side of lead, this is the left side of lead, that allows you to then kind of corroborate. We can come back to this in more full detail. So then the next part for physiology is correlating leads to anatomy. Favorite picture I've seen yet is the one on top. One on the bottom is one worth memorizing. 1, AVL, V5, V6 should rattle off your tongue as those are the lateral leads. 1 through 4 V1s should rattle off your tongue as these are the LADs, and 2, 3 AVF should rattle off your tongue as the inferior leads. You will get asked that many times in the clinic, and they'll say, what are the lateral leads? And you're gonna be able to say 1 AVL, 5 V6. And that's all they want to know. So worth memorizing, totally is relevant when we get to some of the pathology and locating and identifying where it's at. So this is my favorite man and my favorite quote from all of M1, M2 being the first class through ACE curriculum. That is Joel Embiid. He is the process and we need to trust him if you're the Philadelphia 76ers. So rate, rhythm, axis, intervals, hypertrophy, everything else. That's another thing that should rattle off the tongue. Clinically, whenever it's like, how do you read an EKG? Rate, rhythm, axis, intervals, hypertrophy, everything else. And doing the process allows you to stay focused to where you can actually think through it critically and not just jump to what you think you're seeing, but catch the little things such as an arrhythmia or an absence of P waves or wide P waves or wide QRS because you're stepping through the actual steps. So the first for rate, a big box, each big box is 0.2 seconds or 200 milliseconds. You'll hear it referred to both ways. And so every minute has 300 big boxes, and you get that by 60 divided by 0.2, or if you're like me, 60 divided by 1/5, which is the same as 60 times 5. So you get to 300. That's where you get the whole, you can count down by 300 thing you've probably heard about. You're dividing by big boxes. So if you have one big box, it's 300. 300 divided by 1 is 300. If you have two big boxes, it's 150. 300 divided by 2 is 150. Divided by 3 would be 100. 4, 75. 5 is 60. I would hazard if you get below 60, it's not worth memorizing what 300 divided by 7 is. It's somewhere in the 40s. Purely because at that point you should just count and multiply. So we're going to do a practice one. I see Rachel's face. Rachel, do you want to count big boxes on this one?
Sure, I can do that. So here it looks regular for every interval. So it's a little less than 2. So I would probably call it right around 90 or something.
A little less than 2.
Oh, a little less than 2, a little bit over.
Yeah, there you go.
Yeah.
That's perfect. You got it.
150.
I don't know what the rate is on this one, but that's right about where it's at. It's greater than 100, less than, or sorry, greater than 150, less than 300. And it's closer to 150 than it is to 300. So like, I don't know, 170. The other option is to count and multiply. Thank you, Rachel, for jumping in there. So every EKG that you look at is 10 seconds. 10 times 6 is 60. So the number of QRSs you see in a rhythm strip times 6 is your beats per minute. That's the same thing you do when you take your pulse and check your watch and then multiply. Someone else want to hop on really quick and tell me how many are in this? Or Rachel, you can go again if you'd like.
I see 8.
Great. 8 times 6.
48.
Beautiful. And then, okay. So then the next one, rhythm. Basic question for this, is it sinus or is it not? Especially for a M1 to M3, even M4, you're really asking, is it a sinus rhythm, which means is it normal or is it not? There's no such thing as a normal sinus rhythm, it's sinus. If it is not sinus, it is irregular. And so the question here is there a P wave for every QRS? And I almost always do the bottom one on strip, and I just go down and see QRSP, 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 and just verify that every P wave has a QRS. Here, we can clearly see PQRS, 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 PQRS. Perfect. It is sinus. This one, I would hazard that you have a hard time figuring out, is there a P wave anywhere? It's not sinus. That would be VFib because you have wide. We'll get more into that at a later presentation. And then this one, you could maybe pretend that you see some P waves here, like maybe that's a P wave, or maybe that's a P wave, or maybe that's a P wave. But then you got to explain, so what are all of these? Are those extra P waves? And this is not sinus. There are not P waves. There's a bunch of gunk going on in that EKG. That would be a fib, and you can tell it's also irregular. And so the temptation is to jump and try and identify the rhythm. Is it VFib, AFib, torsades? Is it a heart block? Yada, yada. But most importantly, you first want to ask, is it sinus or is it not? And then if it's irregular, you can go hunting for what the irregularity is. So then we get to axis. 2 thumbs up is going to be the way to go. This is a little misnomer. The 2 should be AVF here. So lead 1 in AVF, you're looking at the net deflection above baseline, which means is it pointing that direction? And so on this guy, I'll do this first one, then I'll have Rachel do another one. You have limb 1, positive deflection, so your left hand goes up, and you have AVF, positive deflection, greater above the baseline than below the baseline. So you have 2 thumbs up, you are normal axis, hurrah. Rachel, you want to do this axis?
Yeah, sure. So in this one, first I'm looking at lead 1, that's positive, and then AVF is also positive, so I would call that normal as well.
I would agree. That's actually the same one that got copied on there. That's funny. You want to do this one since it's actually different?
Yeah, okay, so in this one, lead 1 is going down and AVF is up, So using my quadrant, if I do that, AVF is, I guess, the vertical axis. So that would be positive. And then we're in the other quadrant, so right axis deviation.
There we go. Very good. A quick cheating trick: if your left thumb is up and your right thumb is down, it's the left axis because the left thumb wins. If your right thumb, which is AVF, is up and the left thumb is down, it's going to be right axis because the right hand wins. That never worked for me. I always got it confused. And so I always used the quadrants until it really got hammered down. It would either pull it up or draw it out on a piece of paper to make sure that I confirmed. And so this will be the last little piece that we do for today. We won't get into hypertrophy. But the importance of axis deviations indicates that there's a change in heart size. And so when you see pathology here and you see left axis deviation, it means they have something going on the left side of the heart that's caused the heart muscle to increase in size. And if you see right axis deviation, it means there's something going on the right side of the heart, which likely means in the pulmonary circulation, that's causing the heart to increase in size, whether it be an acute process like a PE or whether it be a chronic process like pulmonary hypertension, COPD, chronic bronchitis, or if it's a right-sided cardiomyopathy that's preferentially affecting the right side than the left side, that would be another chronic process. And so these will give you clues to pathology, and then they tell you, hey, I should go look for something here. So with that, we'll pause for today for our 5 clinical minutes, and then take any questions that happen to be in the chat, which I don't know if I can see the chat right now. There we go.
I'll let you know if any come up.
Yeah. Okay. Anybody have any questions? You don't have to put them in the chat. You can also just pop on and ask them. If not, we will sign off and get to work.
All right. Thank you all for joining us. My puppy says good morning. Everyone have a great day. Please join us tonight at 5. One last thing I forgot to mention, we are recording these videos and we're hoping to put them on YouTube so that anyone can go back and watch them. If you have a problem with that for any reason, please just shoot me an email and we can not post this one if anyone has a problem with that. But have a great day, everyone.
Yep. Bye.